Session on implications of expanding access to mental health care. And we have 4 speakers looking at different aspects of this. 2 speakers looking at the expansion in the US under the Affordable Care Act. Another paper with 2 speakers looking at a home visitation program for postpartum depression. And we'll be leading off with a paper from the Netherlands about the effect of an exogenous demand shock. And what that is, I'll leave you in suspense, but we'll find out soon because that's the first paper. And the presenters are going to be, the first paper is Rudy Deuven from the Netherlands Bureau for Economic Policy Analysis and also Erasmus University. The second paper will be Alex Gartner from University of North Carolina, Chapel Hill. Third will be Lin Wen and Yen Lei from University of Texas, Health Science Center at Houston. And then finally we'll have Tim Creedon from Health Equity Research Lab in Cambridge and also from Brandeis University. And we can take a couple of clarifying questions after each paper, but save most of it for the discussion at the end, if that's okay. So with that, I'll turn it over to Rudy Deuven. Thanks.
Okay, thank you very much, all. I'm Rudy Deuven. I'm a researcher from the CPB, the Netherlands Bureau for Economic Policy Analysis, so I'm from the Netherlands. I was here in Boston 4 years ago as a Dutch Harkness Fellow, and it really feels great to be back again here in this town and to feel see all the research here. My talk is about treatment response of mental health care providers after exogenous demand shock. Now first, let me welcome you all here in the room, also people who watch maybe this video abroad, maybe my wife and kids, who knows, so welcome. Before I start, also I want to thank my co-authors. One of my co-authors is Minke Remmersmal, she's in the room as well, so any nasty questions she can answer these as well. And the other 2 persons are Tobias van Vliet, also from the Institute of CPB Netherlands Bureau for Economic Policy Analysis, and Robin Zoutenbier, he works also there. So let me now start with the presentation of my paper. Now this paper is not about, I must apologize, this is not about expanding access of mental health services, but about reducing it. I think in Europe, and especially in the Netherlands, we were quite generous in providing mental health services to the population. All the population is mandatorily insured for all kinds of mental health services, so we really have a broad insurance scheme. That's completely different in the United States, and that's why I think we have this difference here. So this is about the Dutch curve of mental health care sector. I think Carol Proper told already yesterday in the plenary session that in 2006 we went over to the system of managed competition in the Netherlands. So that means that health insurers now buy healthcare services on behalf of their consumers. And that's really a different system than we had before. And in 2008, the Dutch government decided also to put mental health services into this framework of managed competition. So that was really something controversial because it's not really clear whether mental health care is doing a great job about putting it in such a system. And then the first 4 years after mental health care was in this system, we saw a really rapid increase of current mental health care expenditure. It was really big, sometimes double-digit figures. So it was really worrying the government. So then the government thought, well, we should do something about it because otherwise these expenditures will grow and grow forever. So in 2012 and 2013, there was really, the government took really several policy measures in order to curb this expenditure growth. So now I'm going to talk about these policy measures that also define the exogenous shock. So first what they did was they did a reduction in the basic benefit package. Normally we had a very big insurance package. You can see it on the front of this slide. So what they did is that they put 2 types of diagnosis services out of the package. It was adjustment disorders and V codes. And both of these services, now patients had to pay them completely by themselves. So it was not insured anymore, so patients had to buy it themselves. And the other part is for the rest of the basic benefit package, they increased the deductible. So it became more expensive to buy these, to get these health services. And then finally also, to get just, I mean, the government also wants to have some, really get some money, actually feel it. So they did cuts. They cut the fee-for-service type of tariffs. I don't go into detail here, but it's more fee-for-service type of tariffs. They cut it by 5.5%. So the reference tariffs was cut by 5.5%. And also the budgets of the budgeted providers were cut by 5.5%. So that's really a huge shock. I mean, you can feel this. If you cut maybe the basic benefit in 17.5%, you have cut in budget, cut in tariffs, and then you raise the deductible also for persons. So what do you think happens? That's on my next slide. You see there was an enormous decrease in the number of patients getting access to mental health services. You see on the left, the y-axis, see the number of patients, and see before there was a continuous growth of about 2.8% of the number of patients that took out for 4 years. And then suddenly the government stepped in and they did this policy. And then suddenly we saw an enormous decrease in the number of patients. So in 2012, about 11%, and also in 2013. So that was a huge shock to the system. So what we're going to analyze now is how providers, I mean, if you see like 20% of your patients is not coming anymore, and you also have a cut in your budgets, how are you going to handle this? And this is actually the topic of my paper. My paper is about how are providers, how they respond to this large exogenous demand shock. Because it's really an exogenous shock, because I mean it wouldn't be very difficult to prevent this. So there are two types of possibilities they could do. I mean, it's not clearly clear. There are a lot of options if you face such a shock. So one shock is simply you do a big reorganization. So for instance, I see 20% less patients, so you have 20% less revenue. So what you say maybe, well, I lay off some employees and I try to reorganize my system because otherwise I cannot survive. That was possibility one. Another possibility is reallocation. So you simply do things differently than you did before to get the money. So one possibility would be to treat patients longer. The remaining patients you have, you had 100%, now you have 80%, 20% is left to market. You have 80% patients over, so you maybe treat these patients longer. That could be a possibility. Because you feel like you can maybe improve their health. I mean, it could be a good situation to do so. Another thing that could happen is that you eliminate waiting lists. I mean, if you have a overcapacity, then of course it would be a good thing to try to reduce the waiting list. Another thing we saw actually is recoding. People who came in with adjustment disorders, they were very expensive, they couldn't afford it. So what people did, we don't recode these guys or these patients as adjustment disorders, but we code these patients as, for instance, mood, or so we code them differently, so we can keep these patients in the system. That's actually what we saw, but our research will be only on the first part of this slide. Now we have data for 6 years, for 2008 to 2030, so we have all the data in the Dutch healthcare system. And for this research, we made a balanced panel of 858 mental health care providers. 153 of these providers were budgeted providers, and other ones were self-employed. Psychologists and psychiatrists. And we have about 3.6 million DRGs, and this covers about 90% of the total population. Now for us, this research, it's interesting to see what happens to treatment duration and about health status. So that's quite nice in this study. We have a clinical outcome measure, which is the GAF status. That's a general assessment of functioning. Each provider who faces a patient has to provide a GAF score at the beginning of the treatment and at the end of a treatment. So then the difference between the two GAF scores, you can see this as a sort of kind of improvement of the patient, of the health of the patient. And that's what we're going to use in this story. Now what we see here, that's already quite remarkable. So what these providers did was not that they lay off people. It's quite hard to lay off people because most of these people have fixed positions and were salary based. And it's quite hard in such a short time spending to lay off people. So you have the same amount of people and the same amount of people, what can they do? What they did actually, they treated the patient longer, much longer actually, between 20 and 40% longer overall. And if you look at different types of severity of patients, even that they're less severe patients, they were treated longer. Look at here at the x-axis, you see the years, 2008 to 2013. At the y-axis, you see the average number of minutes you treat a patient. Then look at the blue line, the first blue line in the left graph, that's for depression. So normally, you treat till 2008 till 2011, you treated patients for about 500 minutes with a severity of a GAF bigger than 7. That's a less severe patients. And then suddenly this shock is coming in. And then what you see, they increased treatment duration by sometimes by more than 20%. So you see that previously they treated the patient 500 minutes, and then they thought, well, we have to treat this patient longer to gain this money, to gain this income back. And they treated this patient for 700 minutes. So that's about 200 minutes longer. And you see that's all over the floor. I mean, for every type of categories, even for less severe and severe patients, all patients were treated longer on average. And we see that not only by depression, but we see this for a lot of other illnesses as well. So here's the graph for schizophrenia, and you see a similar type of shock. So that was quite amazing. So for us, it's quite interesting now. Is this a good thing or a bad thing? So the only thing to value this is to look at health outcomes, because if you don't know the outcome, you cannot say anything about this shock. So what we're now going to do is this slide is see about this GAF score, the general assessment function. Did it improve if you treat patients longer? Now you see in this graph, we try to figure out that this is the case. That is not the case. I mean, on the x-axis, you see how much longer they treat patients. For instance, you have a 0.1, then it means they treated patients 10% longer or 20% longer. And at the right-hand side of the x-axis, you see 0.4. That means patients were treated 40% longer. And on the y-axis, you see the possible increase in GAF score of treating patients longer. You see almost no increase in the GAF score of treating patients longer. And all these different colors, circles, are different GAF categories and are different diagnosis categories. So what you see actually that they treated patients longer, but we find almost no improvement in the health. And the improvement in the GAF score, that's better. It's not a perfect score to measure health, but that's the only score we have. So this is quite remarkable. So we see that it didn't really had much impact. So the conclusions now of my talk is that budget provided compensated this drop, this 20% drop in income, by potential drop in income by treating patients longer. And this was 10 to 40%, depending on the number of patients, on the type of patient, and without significantly improving the clinical outcome measure. So what we find here, if you look into health economic theory, what does now explain this behavior? The first explanation is the target income hypothesis. I mean so probably it's very important to remain your income, even in mental health care services. And it's also unclear how long you should treat a patient. I think that's also quite nice in the story. So what's an optimal length of treating a patient? You see, if you give providers free room to treat patients, they can treat patients more or less forever or even longer as they wish. And you see, so we feel like this is a nice version of the target income hypothesis in mental health economics. It's also probably flat of the curve theory, because the flat of the curve is like, I mean, probably they were already on the flat of the curve before the shock, and then after the shock they treated longer, but they stayed on the flat of the curve. So we don't see any big improvements in health outcomes. So this is, I think it's a classic example of maybe about supply and use demand. Although I must say there are some limitations here. I think the biggest limitation is that we have only GAF scores. And that's the only clinical outcome measure we have. So it would be nice to have other outcome measures as well to test whether maybe some other things improved. But that's what we not can do, and we don't have any information about that. So let me finish my talk. I mean, this is our third paper in this series. So we did two previous papers in this without business database. The first paper was published in the Journal of Health Economics in 2015. And the second paper is out, and we're trying to publish this as well somewhere. This is about altruistic mental health care providers have better treatment outcomes. So, thank you very much.
Are there any clarifying questions for Ruby?
Can you hear? I speak like this?
Yes, I hear you very well.
So I didn't get, so did you have a parametric approach here? So did you control for the characteristics?
Yes, yes.
I understand that actually in the end, the only value you have for quality is outcome, the GAF one.
Yes.
It's an approach for quality. But I was wondering which are the other things that actually you were controlling for?
Well, we control actually for everything we have in the data. So we control for age, we control for severity. So the idea here is that you control for severity of the patient. So we control for, so you only do the regressions per GAF category, so and we control for severity, and we do it per diagnosis category. Also, we look at whether how a patient was treated, so whether a treatment was completed or was prolonged. So we have all these, actually all variables we have, like age and also we have type of providers, so we have fixed effects for providers we put in there as well. So we included actually any possible variables you can think of in our equation. But I didn't show it up here because I just like to tell the story. But we try to do this, yeah, to try to as good as possible and to explain this.
I think that makes it more robust, actually.
Yeah, that's why we did a lot of robustness analysis as well. I think that's important. But I think that's the next story we're going to do. So to keep this, I mean, this is a lot of data, so you can do a lot of things. And we're trying to do more and more robustness studies and also look maybe at differences across providers, because we have budgeted providers. These have this behavior, but we also have non-budgeted providers who are paid slightly differently. And these providers, they don't show this behavior. So it's very nice to compare these types of providers and see why they differ. So I think that's a really good point for future research, and we're still working on this. But this is just, I mean, with 12 minutes, you cannot do too much. So I think I tell the main thing in the story, and that's it. You know.
Thanks, Rudy. And I've just been reminded by the tech people that we should be using the mics for the question. It didn't occur to me, but because it's being streamed, so for the next time, come up to the mic, folks, if you have questions. But now we'll, thanks, Rudy, and now we'll turn to the second paper. Alex.
You can do it yourself.
Hi, everyone. I'm Alex Gartner. I'm a medical student at the University of North Carolina, and I'm a PhD candidate at the UNC Gilling School of Global Public Health. I did this project with my colleagues in the PhD program, Jason Rotter and Gracelyn Cruden, and this project is entitled, How Has the Mental Health Parity and Addiction Equity Act of 2008 Affected Behavioral Health Service Spending and Utilization? So we know in the United States, many people with mental illness, even people with serious mental illness, don't access any care in a year, much less the recommended levels of care. The most frequently reported reason for not accessing behavioral health services is the inability to afford the cost of care. Now, one potential contributor to that, to high behavioral health care costs, prices in the United States, is that historically insurance plans, private insurance plans in the United States have applied higher cost-sharing burdens for mental health services. So in the United States, if you have private insurance and you go to a psychiatrist, traditionally insurance would pay less of the bill than if you went, less of a percentage of the bill than if you went to an endocrinologist or a cardiologist, for instance. That was supposed to change in 2008. Congress passed a really big piece of legislation called the Mental Health Parity and Addiction Equity Act, and it required private large group health plans that offer behavioral health service benefits to offer them at parity with physical health benefits starting in 2010. This wasn't the first parity measure. There were state laws before this, and there were other federal efforts too. What was different about the Mental Health Parity and Addiction Equity Act is that it was federal and it was far-reaching. It applied broadly to cost sharing, such as coinsurance, to treatment limits, such as how many sessions of psychotherapy you could have in a year, and to non-quantifiable limits, such as medical necessity review, where an insurance plan might say, you can go to therapy, but every 6 months we need documentation that you still need to be in therapy. At the time of its passage, the Mental Health Parity and Addiction Equity Act did not apply to individual or small market plans. It did not apply to Medicare, which is the public insurance plan for adults over age 65 in the United States, and it did not apply to Medicaid, which is the public insurance plan for people with disabilities, pregnant women, children, and other groups. So there have been previous studies of state and federal parity measures in the United States, and they generally found cost decreases for consumers, but no changes in utilization. So we can say that's good that costs decrease for consumers, but it's a little disappointing that there's no change in utilization since we know so many people aren't using any healthcare who need it. But the Mental Health Parity and Addiction Equity Act, like I said, is further reaching than previous policies, so perhaps there's reason to think that in this case the results may be different. So far, there have been some small-scale studies of the law that have yielded mixed results with commercial data from private health plans. There was one great analysis done by Tim Creedon using nationally representative survey data that suggested that the law did not increase access to behavioral health services. This was a difference in difference analysis comparing private insurance, people in private insurance with people in Medicare, Medicaid, and the uninsured, and I think looking primarily at the extensive margin, whether people used any services within a year. So we were interested in looking at the same question. We were interested in the extensive margin. Does this law lead more people to use any services? We were also interested in looking at the intensive margin and looking at whether there was any effect on spending, which previous research suggests there could be an effect on spending. And we hypothesized that parity will decrease prices for patients for behavioral health services that'll lead to lower out-of-pocket spending for patients and higher utilization. So we're looking at 3 outcomes. The first outcome is use of any behavioral health services, which we define as any visit with a psychiatrist, psychologist, or social worker. That's a narrow definition, but we think that's closest to how an insurance plan would define behavioral health services. They don't usually use diagnostic codes or specific treatments. They'll usually use provider type or facility type. We look at number of behavioral health visits among those with any visit, so that's the intensive margin. And we look at the percent of the behavioral health service visit spending that is paid out of pocket. So we don't want to just look at overall spending, because as you imagine, if prices fall and people use more services, their overall expenditures might stay the same or they might even go up. We're really interested in what percentage of the spending is paid out of pocket by patients. And we're using this data set called the Medical Expenditure Panel Survey from the United States from 2006 to 2014. This is a yearly survey of a nationally representative sample of US households that has an overlapping panel design where each person is in the survey for 2 years, and there's a panel that starts every year and one that ends every year. And we're looking only at office-based and outpatient visits for this study, so we're not including inpatient or emergency treatment. So we're using the same basic approach that Tim Creedon used in his paper, which is doing a difference in difference analysis comparing privately insured individuals to uninsured, those in Medicaid and those in Medicare who weren't affected by this law. I'm going to show 3 specifications. One is an event study specification that shows the year-specific effect of being privately insured with year fixed effects. So this specification doesn't have a pre-post indicator. It doesn't know when the law came into effect. And then I'll show a classic difference in difference specification with a pre-post effect and also year-specific fixed effects, and a difference in trends specification, which looks at whether the trends for each group changed over time, and that allows us to relax a little bit the assumption of parallelism in difference in difference. I'll skip over the unadjusted trends just for the sake of time. We can look at them later if you're interested. To control for time-varying differences between groups, we included in all the models several variables: age, sex, race, ethnicity, income, a measure of psychological distress called the Kessler-6. So I won't go through all of these characteristics, but I'll just point out a few that are interesting. The Medicaid group had the highest proportion of people using any behavioral health services. That's not surprising. We know Medicaid is the single largest payer of behavioral health services in the United States. I thought it was interesting that in all of the groups, if people used behavioral health services, they tended to use, on average, the same number of visits. And it's also interesting that the out-of-pocket share of payment was very similar between the private group and the uninsured, which is something to think about the next time you pay your private insurance premium. So this is the event study specification. This is for the outcome, any behavioral health visit. So right now, so here we have the comparison with Medicaid, with Medicare, and with uninsured. And right now I'm just showing you the pre-2010 coefficients. And what we want to look for here is that the coefficients aren't changing much from year to year, because we want to see that the trends are parallel before the law. And indeed, it doesn't seem like they're changing much year to year. After 2010, what we'd like to see, if our hypothesis is correct, is for the coefficients to start going up relative to the coefficients before the law, if private insurance is doing better compared to the other groups. What we actually see is that all the lines stay pretty much flat after the law. And we see this again for any behavioral health visits among people who had behavioral health visits. And we see this again in the out-of-pocket share that's paid. So in our classic difference in difference specification and difference in trend specification, again, we look at 3 outcomes, 3 comparison groups per outcome, and we don't have any statistically significant results in the direction that we would expect. We have one statistically significant coefficient at a 0.05 level that actually is in the opposite direction that we would expect, where we see private insurance is doing worse relative to Medicare in their trend in any behavioral health visit, which you can actually see in the unadjusted trends that I skipped over, but we can go back. And these results are robust to a number of different specifications. We ran models with panel controls instead of year fixed effects, with log-dependent outcome, subsample of individuals in mental health distress. We excluded 2014, which is a year where some other policies changes, and other models as well. So there's no evidence, unfortunately, that the Mental Health Parity and Addiction Equity Act increased behavioral health service utilization or decreased out-of-pocket spending. There's several possible reasons for this. It could be that there were contemporaneous changes in insurance design that negated any of the effects, such as higher deductibles or more use of managed care approaches. There could be contemporaneous changes in policies that negated the effect. The Affordable Care Act, many of the measures came into implementation in 2014. MIPA is a law that introduced behavioral health parity in the Medicare program starting in 2010. So you might wonder, why did we include Medicare as a comparison group? It's because MIPA had a gradual implementation between 2010 and 2014, so that might actually explain the reason we see a negative coefficient on Medicare compared to private insurance. So that's a bit encouraging, because it suggests maybe actually MIPA had an effect, and that's something that we're looking into. There could be supply side restrictions, too few providers, even if people have better insurance coverage. The effect might be limited to certain populations or certain states that didn't already have parity laws. Or there just could be a lack of enforcement and awareness of the law, and there is some anecdotal evidence that this might be the case. So in conclusion, parity itself may not be sufficient to address the financial barriers to care access in the United States. It's possible future studies would be better off focusing on barriers that aren't necessarily specific to behavioral health, such as lack of insurance and high deductibles and other barriers. So that's all for now.
Are there any clarifying questions for Jeff? Would you come up to that mic?
Good morning. My name is Carolina Herrera. I'm a doctoral student at Boston University. I did some work on this a couple years back, and a very senior economist turned to me and said, well, the point of this law was not to change costs. So can you address what the intent of the law was with getting parity in benefit design, and why benefit design may not have been intended to make this more affordable?
Yeah, I think that's a great point. I think Tim might also have thoughts on that. I think you're right. I mean, I think it depends who you ask. You know, I think advocates had been pushing for parity for many years, and I think most of them hoped it would improve access by decreasing costs. But you're right. Another way of introducing parity is to just raise physical health service, costs, right? Because that would also get you at parity. So, I think that point is correct. It's not necessarily the intent of the law. I think it's more of a question of equity for many people than it necessarily is a question of improving access or utilization.
And the second question I have about this is, you were looking at you're responding to the MAP survey, you're looking at all mental health and behavioral health services. Would it, or have you done the analysis where you've broken out substance use, broken out mental health by different types of care? Because we've seen that, inpatient care is inadvertent, typically. Emergency room care is inadvertent, typically, but office visits are not. So have you done that analysis?
We haven't looked at inpatient or emergency care yet. The cell sizes are very small, even for outpatient care. So it's just hard to start parsing it out more than that.
Okay. And last question is, going back to the interesting result with the uninsured, I am studying pediatric mental health in my doctoral work, and I'm starting to think that there is a shadow economy for mental health services that will never be captured by the claims data. Obviously, MEPS should capture that because it has both, it doesn't rely on claims. Do you think the effect you're seeing is effectively people going out of pocket to individuals who are providing them care not through a insurer-paid system, who instead are just paying out of pocket fully for the care?
It should. I mean, MEPS should capture that.
No, I'm saying, is that potentially why the uninsured and the insured are paying about the same amount?
So I think there could be a lot of reasons. I think one reason, which I alluded to, is that it's just really hard to find in-network providers. Even where I live, there's a huge health system, and it's still hard to find in-network psychiatrists. You're probably going to be paying out of pocket, and you're probably going to be paying more, a higher share than you would otherwise. So yeah, I think it'd be interesting to compare private and uninsured in other disease areas to psychiatry and behavioral health.
Thank you.
Sure.
Good morning, everyone. So there's two of us here this morning. My name is Yen, and then this is my colleague, Lynn. We want to really thank you for giving up the opportunity to have Sunday brunch to come and hear us present this morning, because it's really early, and we really appreciate seeing all of your faces. So Lynn and I are going to be talking about the cost-effectiveness analysis of HOPE, a home visitation program for women with depressive symptoms. So I kind of use a similar map like this to get here today on the green line, was it? Yeah. Okay, so our agenda is we'll just give a brief overview of maternal depression, and then we'll talk about the program, and then I'm going to turn the mic over to Lynn to talk about program evaluation. Okay, so maternal depression, it seems that about 1 in 7 women suffer from postpartum or antenatal depression in the US. And suicide accounts for about 20% of postpartum deaths and is the second most common cause of mortality in postpartum women. ACOG, the American College of Obstetrics and Gynecology, recommends that all pregnant women be screened at least once during the perinatal period, and then also again in the postpartum period. And the symptoms of postpartum depression are loss of appetite, insomnia, lack of joy in life, and can lead to poor childhood outcomes like lower levels of breastfeeding and kind of not the typical attention that you would see, and then less intense bonding between the mother and the child. So what does it look like when we don't treat depression? Well, there was one study that was done out of Minnesota that showed, I think the sample was 10,000 mothers, and it looked at the cost of not treating maternal depression, and we see costs across the 2 generations of about $22,000. These costs, as shown on the slide, are related to loss of productivity, not working, and then also treating low birth weight babies, preterm deliveries. So what can we do to prevent this loss of productivity and these clinical outcomes? Well, we see that there's significant racial ethnic differences in depression-related mental health after delivery, and that we see that this really affects women who are kind of among the lower income echelons. One thing that the literature has shown us is that home visits by health workers have been associated with improved maternal and child health. And so at UT Health Houston, as part of ACA and the Medicaid 1115 waiver, Texas was one of the states that decided not to expand Medicaid, so academic health institutions like UT Health were able to appeal and apply for these fundings directly to CMS. And so one of our programs is called Thrive. It's a reproductive age health program covering everything from preconception to healthy eating, active living, and one of the components is called Hope. And basically this program, and you can find more information on the website, looks at women who are at risk of perinatal or postpartum depression. And so as far as the recruitment, it happens in our clinics. Patients receive the EPDS as part of their prenatal visit, and if they score more than 10, then they are asked to meet with a social worker who does a motivational interviewing session with them, and then ask them if they would like to enroll in the program. And then depending on what is discovered in the MI session, then the patient can either enroll, decline to enroll, or is referred to other resources if their depression is more immediate and needs immediate attention. The two screening tools that we use are the EPDS, Edinburgh Postnatal Depression Scale, which assesses depressive symptoms. It's a 10-item questionnaire with a range of 0 to 30, with higher scores indicating more severe depressive symptoms. And then the second tool that we used was the Brief Symptom Inventory 18, which looks at general psychological distress, there's 3 domains: somatization, anxiety, and then the last one is escaping me right now. The range is 0 to 72, with higher scores indicating more severe psychological distress. So this is the process flow. At baseline, we administer the EPDS and BSI 18, and kind of similar to, I believe Alex was talking about, the women receive 4 to 6 home visits. And then at the last home visit, we re-administer the 2 screening tools again, and then twice again at 3 months post-follow-up, 3 months follow-up, and then 6 months follow-up. Okay, at this point, I'll turn it over to my colleague, Lynn.
Okay, thank you, Dr. Lee, for a nice introduction. And I'm now like to present the program evaluation part and with some interesting results. So we conducted cost-effectiveness evaluation of the whole program among mothers who received services from October 2014 to September 2016. This is a pre-post analysis on whole participants who completed both pre-test and post-test score assessments of BSI 18 and EPDS score. The outcomes we evaluated include depressive symptoms using EPDS assessments. The second outcome is psychological distress using BSI 18. And the third outcome is cost-effectiveness analysis. For clinical outcome, we compared the mean pre-test and post-test scores of BSI 18 and EPDS. We also compared the percentage of individuals who screened positive for depression between pre- and post-intervention periods. For cost-effective analysis, it was conducted from healthcare providers' perspective. We measured the mean cost per unit change in BSI 18 and EPDS score, and we also calculated the mean cost per reduction in the number of depressed women. The program costs included costs of office supplies, assessments, transportation, and program personnel. The costs were presented in 2014 US dollars. So here are the interesting results. Overall, we have 169 HOPE participants, and 48 of them were Black, and 44 of them were Medicaid or low-income uninsured population participants. So this is the targeted population of our program. For the outcome in depression using EPDS score, there were 52 patients completed both pre-test and post-test assessments. There was a statistically significant improvement in score with an average reduction of 7.48 units. This reduction in score in pre-test presents the reduction in the severity of depression. Impressively, the percentage of patients who were depressed was reduced by half, from 52 patients at pre-test to only 22 patients at post-test. In terms of the assessments on psychological distress using BSI-18, there were 32 patients who completed both pre-test and post-test assessments. And also, we saw statistically significant improvement in score with a mean change of almost 14 units. And it represents the reduced psychological distress over time for these population of 32 patients. And one noticeable outcome for these program for this group of patients is that 6 patients have no distress at all at post-intervention. For cost-effectiveness analysis, we calculated an average cost per visit of $131. We found out that it costs $88 per decrease in EPDS score and costs $47.86 per decrease in BSI-18 score. We also found that it costs us only $1,200 to help getting one additional woman out of depression. So the improvement was achieved as a moderate cost. So we can probably say that the whole program demonstrated a significant benefit in maternal outcomes presented by the reduced severity of depression and reduced psychological distress. The health improvement was achieved at a moderate cost, suggesting the program is cost-effective. Even though we have these very promising outcomes, there are a couple of limitations that we can address in future work. First is the small sample size for the analysis, only 52 patients for EPDS and only 32 patients for BSI-18. The reason is that among 169 HOPE participants, a lot of them are still under the program and haven't been discharged yet. So if we run the program longer, we can have a larger sample size. The second limitation of the program is that the variation in response to dosage. Because this is a voluntary program, so even though the social worker consult and recommend patients for the dosage, it means in terms of the number of home visits, but it is at the patient's discretion to exit the program at any time. So if they stay longer in the program, the outcome could have been even better. So there's all the interesting results that we found from our programs, and we are very happy to answer any questions.
Gosh, we blew you away. Okay, if you have questions, here's our information, and thanks again for your time.
Okay, there's a question over there. Yes, please.
So again, I'm Carolina with VU. Can you please go back to the slide where you talked about the cost of the intervention? Okay, so let me try to understand this here. In order to decrease the EPDS score by some amount, it's $88, which that makes sense, and then it's another $47 of expenditure to decrease the BSI score. But then if you want to actually reduce the number of people who are depressed, it's about $1,200 for the entire physician office or for the patient?
So we calculated the cost per visit of $131. So each patient will have a number of home visits, right? And then if a patient have EPDS score of 10 or more, they will be categorized as having a depression. So we have, among these patients for this analysis, for EPDS analysis, 52 patients. We have 51 patients who were depressed. And then we have the total cost for these population, and then divided by the change in, you can see it here. So we have the change in the number of women who were depressed, went down from 51 to 22. So we came up with a cost per reduction in the number of depressed women of $1,200.
And that's $1,200 for all those women?
For additional,
For each woman?
Per woman, yeah.
So what is the average postpartum cost right now in terms of care? How much are we paying postpartum to give them treatment?
so this program is the home visitation program. So we calculated the cost, including all the assessments, all the home visitations, and including personnel, supplies, and all these things. So
Right.
the average cost per patient, I think, the average cost is about $600, $700.
$600. So we're talking about doubling the cost in
So
order
I
to...
mean, are you talking about the cost of treating or the cost of depression?
So what I'm talking about is that if we look at women and the expenditures in the postnatal period, and we look at that first 6 to 12 months, and we ask ourselves, how much are these women paying out of pocket and how much are the insurance companies paying for their care? How much additional money is this? Because $1,200
That's, yeah, so.
represents
Yeah,
a fairly
so-
significant amount of money relative to what would otherwise be spent on these women.
This program was at no additional cost for the participants, for the women. This $1,200 is the cost of the institution or the provider. So I mentioned earlier in the program overview that the funding for this program was part of the Medicaid 1115 waiver program, and so our institution absorbs all these costs. But I think the $1,200 is kind of an interesting figure to think about, like if you're like a community health center and you're thinking about adopting a program like this, how much it would cost you. And then based on kind of what Alex and you discussed earlier, if you were wanting to like kind of contain the cost or whatever, then you would have to look at this. But we think $1,200 is very reasonable
Okay.
from the provider perspective.
Right. And I can't argue with that if it's stopping someone with depression, but what I can say is that from a cost perspective, you're talking about potentially increasing the cost here by at least $1,000 per woman in order to decrease the likelihood of them having depressive symptoms. And that might be something that's going to run into expenditure problems or, institutional problems when you try to implement the model. So that's what I'm trying to understand how this was, I think you had said something around the lines of this was a cost-effective intervention. And I'm just seeing it's adding costs and providing services that were not previously provided, which is great. But I'm trying to understand how that might be effective given we don't have an alternative.
So it could be, maybe we're working under different definitions of cost effectiveness, because the way that we're using it, and correct me if I'm wrong, Lynn, it's the cost per unit change in clinical outcomes. And so we're looking at it from a provider perspective.
So this is just a comparison of having program versus no program, and then the patient doesn't have to incur any cost. That's why we found out that this is just the additional cost to improve an additional outcome.
Thank you.
I think we probably better leave it there. I think basically the questioner's point is looking at budget impact. So an intervention can be both cost effective and be hard to implement because of the budget impact. Both things can be true, but we can resume this in the general discussion. But now I'd like to introduce the last speaker, Tim.
Let's see if I can adjust this. Great. Thanks everybody for joining us this morning, and thanks to my fellow panel members. I've learned a lot from your presentations, and it's nice to see how our work fits together. Different groups and internationally as well, not just expanding but reducing access to care. That's important to think about. As Alex alluded to in his presentation, toward the tail end of his data, looking at the 2008 Parity law, we also had, of course, the Affordable Care Act, which began some insurance coverage expansions overall in 2014. So I'm going to kind of pick up at differences at 2014 and see about how access to mental health care has changed. in that time period, and I'm going to share some results with respect to racial and ethnic disparities in access to care. And I really appreciate the support of my co-author and mentor, Dr. Benjamin Cook, who I've been working with at Cambridge Health Alliance, and also Dominic, who's my dissertation chair, and has along the way taught me a lot of the health economics and quantitative methods that I've been using in this work. So in 2014, Affordable Care Act health insurance expansions began to kick in via Medicaid expansion, state-based insurance marketplaces for individuals to buy insurance when they couldn't get it through their employer, or for small employers to provide an option. And it also began to extend provisions of the parity law that Alex spoke about to other forms of health insurance, and to make mental health benefits known as essential health benefits that needed to be covered by all plans. So we wanted to know, how did some of these insurance expansion policies affect things for people with a need for mental health treatment? So we're going to focus on not the whole population, but people with identifiable mental health treatment needs. And we're going to see if there was any difference in 2015 versus 2014. We're going to look at insurance expansion, insurance coverage overall, whether there was increased access to any form of mental health. So this would be the extensive margin that Alex was talking about. And we'll look at some outcomes in terms of what were some barriers to treatment among people who reported not being able to get treatment. And then, as I said at the top, we'll see if any of these things varied by race and ethnicity. From a health economics perspective, we might think about what the Affordable Care Act could do in terms of consumer theory, and how, in very simple terms, when you expand health insurance, it could increase demand for mental health treatment by reducing the price, and also reducing risk and uncertainty with regard to how much is it going to cost you, can you know, and what is your sort of financial risk associated with seeking treatment. But when you expand health insurance, it doesn't do too much to affect supply side constraints, such as, are there enough providers in your community so that there's somebody who can treat you, and are they the right kind of provider for you given what your clinical need is and what your background is, demographically, socioeconomically, and so forth. Does the provider that you're looking to work with accept insurance at all, or will you have to pay out of pocket? And how long does it take you to see a new patient, a new provider for the first time? If it's going to be a long wait, maybe even if you have a need for treatment and you have insurance, you might choose not to go for it. And then health insurance expansion doesn't address other demand side constraints like stigma, ambivalence about seeking treatment, and or a lack of familiarity with what your needs might be at any given time. Also, there's a fair amount of literature that shows that when you ask people with insurance whether it covers mental health care, people don't necessarily know. Health insurance is complex, the different provisions that are involved, and it's hard to keep track of all of it for lots of consumers. I was working with Dr. Cook and I were working with the National Survey on Drug Use and Health to do this analysis. It's an annual cross-sectional survey. Each annual panel or annual cross-section is independent of the ones before and after it. And nationally representative, usually about 55 to 60,000 people per year, representative of the full U.S. civilian population. A lot of good measures of behavioral health status, access and utilization of treatment, and lots of different demographic, socioeconomic covariates. For our analysis, we restricted our focus to adults aged 18 to 64. We thought these would be the folks that would be most likely to be affected by the Affordable Care Act insurance expansion. Children would be covered by CHIP if they couldn't have employer-based insurance in many cases, and above 64, we'd be looking at Medicare, which wasn't affected. We're focusing on people with sort of demonstrated need for mental health care, and to do this, we looked at people who met criteria for past year serious psychological distress. This is based on the widely used Kessler-6 scale. It doesn't really speak to any specific diagnosis, but gives you a sense of how much difficulty in terms of their emotional condition people were having in the last year. And then in terms of looking at racial and ethnic groups, we compared people who self-identified as white to people who self-identified as Hispanic, Black or African American, and Asian. We also had data on people who self-identified as Native American, Alaskan Native, Native Hawaiian, other Pacific Islander, more than one race, but the cell sizes for these racial ethnic groups were so small that it was hard to do anything statistically with them. We had a observational pre-post design looking at 2008 to 2013 before ACA insurance expansion, and then separately 2014 2015 after the expansions took place. And we looked at overall trends pre-post, and then also we did a comparison across racial ethnic groups. We did all of these in a linear probability regression model framework. The overall trends were simple adjusted pre-post differences for all respondents with serious psychological distress, whereas for looking at racial ethnic disparities, we did a difference in differences analysis, looking at differences in time and differences between racial ethnic groups. We controlled for a number of demographic, health status, and socioeconomic measures, but we excluded the socioeconomic status measures from our disparities models to try to adhere more closely to the Institute of Medicine framework or definition of disparities. I could talk more about that maybe in the question and answer period if people have questions. First, if we look at just like the overall prevalence of serious psychological distress among all adults 18 to 64, we see that overall and across racial ethnic groups, it was pretty stable throughout the entire time period. So we don't see on a compositional level too much going on. Overall trends, we can see that among people with serious psychological distress in 2014 and 2015, there were significant increases in overall health insurance coverage. And then in 2014, we saw a significant increase in any mental health treatment in the past year relative to the 2011-2013 period. But then in 2015, that trend was reversed and we went back to a level that was consistent with the pre-ACA period. So that's a finding that warrants more investigation. And then if we look at people who said that they self-identified or perceived a need for treatment, but weren't able to receive it in the past year, we see that that stayed stable. So we don't think that the regression in 2015 is because there were fewer people with quote-unquote unmet need. It might have been for some other reason. If we look at some of those outcomes by race and ethnicity, we see that minorities shared in the gains that we saw overall, but they didn't improve their position relative to whites, which is the first group of bars. Hispanics started off significantly lower, but and increased their coverage rates, but they didn't catch up. And then for blacks and Asians, after adjusting for other characteristics and looking at people with just serious psychological distress, you see a pretty similar pattern and levels for people who identified as being white. Across mental health treatment rates, you see consistently lower rates for minorities compared to whites, and no improvement after the ACA began to expand coverage. And again, this is an interesting finding. It was minority folks, Hispanics, blacks, and Asians, all reported lower levels of unmet need, but that didn't change at all relative to whites over time. Once we looked at some outcomes in terms of among these folks here, people who self-identified a need that wasn't met for treatment, if we looked at questions that people were able to answer in terms of why they didn't get treatment, cost was actually very common overall, but it was significantly less frequently reported as a barrier for Hispanics, blacks, and Asians compared to whites. And then not knowing where to seek treatment and not wanting other people to find out was significantly more common among Asians compared to whites. So these might be some differences within and between groups that are accounting for some of the racial ethnic disparities that persist post-treatment that wouldn't be affected by insurance coverage. And then if we look at people, there's a question in the NISDA about if you have private insurance, do you know if it covers mental health treatment? And what we see is, depending on your race or ethnic group, you would answer this question differently on average. People who are Hispanic, black, or Asian were less likely to say that their health insurance covered mental health benefits, and were more likely to say that it did not. And Asians were more likely to say that they weren't sure if it did. So there's a disparity here in terms of awareness of whether you have insurance, whether it covers mental health. So just to wrap up, we saw overall no reduction in disparities in 2014 or 2015 in insurance coverage or mental health treatment rates. Although a couple of our racial ethnic minority groups did make gains, they didn't make gains relative to white individuals. All minority groups were less likely than whites to report that they had an unmet need for treatment, so that might explain a piece of the puzzle. And then minorities with private insurance were less likely than whites to report that they had mental health benefits. A few limitations with this analysis. These are self-reported measures that, there could be some bias or difficulty remembering. Common self-report problems with survey instruments. And then our past year measures have a problem where if you're saying, yeah, I got treatment in the past year, for like in 2014, for example, you could actually be speaking about treatment that took place in 2013 before insurance expansion took place. We did this analysis using public use NISDA files, and therefore we weren't able to account for state level differences in need and supply and pre-existing policy environments. And then we weren't able to account for other unobserved changes that might have taken place in 2014 and 2015. So we do see, as the Affordable Care Act set out to do, increases in insurance coverage, and but we don't see any improvement in disparities, and we don't see any improvement consistently in mental health treatment rates. We need to find probably other non-insurance focused policy levers to find ways to get more people who need treatment to be able to access it in the future. Thanks.
So if all the speakers would like to come up on stage, we can open up to general discussion questions for them. Bring your questions up to the mic.
Hi, Sandy Juba from the University of Leeds. So I have just one question for the last speaker to start with. Don't you think that actually the fact that white people are reporting more needs for care that are unmet is more related to expectations that they will have in terms of care they should receive?
No, I think that's a good point. From this data, we can't, we can only speculate about what is driving that difference, but for whatever reason it is, it's certainly going to make a difference in who's seeking and expecting to receive treatment. So I think that's something that needs to be addressed if we want to close any of these gaps that have continued for a long time.
Yeah, I really think individuals have extremely different expectations in terms of the care they should receive. I had another little point from the prior presentation. So in the end, you ended up with a much smaller sample, right, of your individuals. And so I was wondering, what do you think about people who didn't reply? So particularly those that you were expecting outcome from, but didn't come. Do you think that they are the one with actually the highest problems in mental health, which would mean that in the end, your study is extremely biased, which is, even if you do have, I think it was like 3/4 and 1/4. So 3/4 of people who did improve, and then just a quarter of them didn't improve. But actually, what about all the others that you didn't get, which were actually more than another 50% of the sample? And so are you expecting once to observe those data, or are they really lost for follow-up, which would mean that actually maybe you're losing the people that are in the lowest health, mental health?
The first part. Okay, we're going to give you a two-part answer because that's how we roll up here. Okay, so at the recruitment phase, you notice that there was 3 options of what would happen to a participant. So with the EPDS scores at baseline, if they are those kind of more severe scores, we didn't enroll them in our program. We connected them immediately to care. And so of those who were kind of like the more manageable depression that would be able to be addressed by a home visitation program, probably, I can't remember exactly, but I think we had of those who were eligible, about 60 to 75% enrolled. So we don't know. There could be a response bias. And that's from the recruitment side. Now Lynn's going to talk from the evaluative side.
I guess your question is about the small sample size, right? So, but actually, when I talk about small sample size, just because we have 169 patients. However, a lot of them are still under the program. The program is going on. So they have to have at least 4 minimum home visits to be discharged from the program. So that's why they don't have both. Woo! That's why they don't have both pre and post-test assessments. That's why we don't have their scores for analysis. So you say that you can see that we have 52 and 32 patients for both analysis. It's just because they completed both assessments. It's not because they just got out of the program or anything like that. So it's just all of them have an average improvement.
Yeah, and
I hope that it answers your question.
Yeah, so stay tuned. I think as the program continues to be implemented, then we'll have higher numbers, and then we can maybe circle back and address what you're saying, like what happens for the women who decide not to complete the program. Are they really more severely depressed, or do they get better? We don't know that. Thank you for your question.
So while people are thinking of other questions, I'll just ask one to Rudy. And so, Rudy, your paper was describing a situation where providers became more motivated to prolong treatment. And so, it's a demand inducement story. But for induced demand, we know that it takes 2 to tango, because the provider has to be willing to provide the visit, but the patient has to be willing to accept it. And you'd said that there was this increase in deductibles as well. So I was wondering, were these additional visits, they were beyond the deductible, so the patient was not affected, was not having to pay extra cost sharing to to accept these visits? Because otherwise you'd think they would resist.
Yeah, I think that's a very good question. I didn't actually specify the cost-sharing theme. Actually, it is the case in the Netherlands like that you just pay, you have a deductible, so you pay 100 minutes for the first, 100 euros for the first 100 minutes and 200 euros for the second 200 minutes. So all these people are just above. So after 200 minutes, you don't have to pay anything more, so then it's for free. So after 200 minutes, all your treatment is for free, so then it's just like, I mean, and also the provider can then provide any treatment he wants. So it's not like co-payments. I mean, we only have deductibles in our system. So it's... no.
I had a question for you too, Rudy, born out of ignorance of financing in the Dutch system. Is it possible, do providers offer like private out-of-pocket treatment, and do consumers make use of that, or is that not something that would take place? Would that be another potential consequence of this policy change, people being forced to consider paying more out of pocket?
Yeah, I think it's quite interesting what happened to these people who, these 20% people who didn't go actually to curative mental health care. So what they did actually, they went probably to primary care, or they went to other sources, and a lot of people even didn't get treatment at all. So I think it is a very nice and interesting question. What happened to these 20% people who didn't receive care? So some of them treated care outside of the system, at least after the curative healthcare system. So, but we cannot observe these because we only have information about the curative healthcare system. So some of these patients got treatment from the primary care sector. And I know that one person in the Netherlands, and also he's a Harkness fellow, is doing a study on this. So what happens to the people? That's quite important, because that would be familiar to the type of study you're doing. So if you increase access, well, what happens to these people? So I think that's, but my story is more about if you have a lot of access, it's more about the marginal, how much should we give these people? And I think you should be very careful I think that's a very hard question. To how long treat patients. Yeah.
Thanks.
I'd just like to say I really appreciate you all taking my questions. I'm very interested in this subject, and I'm moving from being a cost claims person and a workforce person into mental health, so this has been very helpful. I'm hoping to get responses from all of you on two questions. They may be interrelated. The first question is, have you considered the cost of time in your analyses, or is that just something because of your data or the subject matter is not really important? Looking at those non-response rates, either in terms of people staying in the study or people not responding or uptaking services because of a lack of supply. The second question has to do with stigma. I saw we had one slide on stigma, which I thought was great, but I'd like to get your thoughts on what you think stigma might be doing right now in affecting utilization. Thank you.
I actually had a couple of additional slides at the end, looking overall at stigma. Yeah, so here, oh yeah, make it larger. So this is stepping away from the racial ethnic disparities analysis and just looking overall. There was one question in the NISDA where folks who said that they had a need for treatment but didn't get it, well, why not? One answer that you could provide was, well, you're concerned that neighbors or your community would have a negative opinion of you, or you didn't want others to find out you needed treatment. And with the first response, we see that both relative to 2011, 2013, both in 2014 and 2015, people responded that that was an issue more frequently. And then it was non-significant, but we do see maybe, trending towards an increase on the other stigma question that I looked at. So this kind of puzzled us, like, well, why would stigma in these measures at least be increasing in the last couple of years when, if you look at the sort of the history of being aware of mental health needs and the validity of mental health treatment in this country, we're at kind of a high water mark in many respects. So, I mean, we're in turbulent times, I guess. There have been a lot of negative reports, you know, with gun violence in this country about mental health, so that, you know, that could be one thing. But we do see some evidence that stigma not just remains a problem, but is, by a couple measures, even a little bit more of a problem than it was a few years ago.
Hi, okay, so your question about the cost of time, for our Hope Home Visitation program, we felt like it was not, because we were able to visit the women in their homes at non-traditional times like weekends and evenings, we hope to reduce that barrier of time, but maybe some of the women, and I'd have to look at the data again, decided not to enroll because we asked for a commitment of 4 to 6 sessions over 12 weeks. And so that is a lot. Okay, and then your second question about the stigma, yeah, that's definitely a factor. With the home visitations, it's in their home, so it's relatively less stigmatizing than going to a mental health setting. And then another way that we've tried to combat this issue is to co-locate our behavioral health services with primary care and just have one entrance so it doesn't look. So that has helped a little bit, but again, we're not really collecting data on that, but we feel that we are seeing more because when we have new therapists in behavioral health join, I mean, within months, they're booked 3 to 4 months out. Okay. Rudy?
Well, thank you. Well, I think in my story about, I think the time problem is interesting, but what you see actually, I think that the provider is actually the person or the psychiatrist or the psychologist who is actually making the decisions, and I think most people simply follow these decisions. So, and that's what happens, I think, in a lot of these cases, because I think they feel like the provider is the person with a lot of knowledge, and there's a lot of asymmetric information here, and I think many patients simply follow the provider.
So I think you mentioned 2 areas where we need to do a lot more work on as a field. I think supply is a huge problem in the United States, both in terms of geographic distribution and in terms of accepting and participating in insurance plans. And I personally haven't seen a lot of great work on why mental health providers don't participate more and what policies could be put in place to encourage that and whether that would make a difference in access. I think stigma is incredibly important. When I see something like, not to criticize the Dutch government, but if you could imagine, cardiology prices going up and suddenly instituting these really strict cost sharing because, policies to restrict them, you might see that really differently than we do in mental health. I think there's often an assumption, and I think goes back to a lot of important historical developments, that mental health is not as important, it's not as valuable, it's not as effective. A lot of the people who use mental health services are the worried well. So I think it's always legitimate to look at whether the more services are making a difference, that we should absolutely be doing that. But I think there is a lot of stigma even among policymakers. The truth of parity in the United States, from my understanding, having studied this, is that parity was politically not possible until studies started showing that parity measures didn't really make a big difference in utilization. So it's sort of, it's sort of ironic, it only becomes politically feasible once we know it's probably not going to have a big effect at the ground level.
Okay, well, if there are no other questions, let's just thank the speakers one last time and thank the audience.